All right, Brian, are you about ready?
Yep, I'm here.
Okay. All right, so thank you everyone for coming to today's webinar. For those of you not familiar with the Athletic Trainers Osteoarthritis Consortium, or the ATOAC, we are a group of about 65 athletic trainers across the country at this point. And our mission is to raise awareness, promote research, and advance the best practices in prevention and management of osteoarthritis. My name is Abby Thomas. I'm on faculty at the University of North Carolina at Charlotte, and I'm on the executive committee of the ATOAC. And I'll be moderating today's webinar. So we have Dr. Brian Pietrosimone today from the University of North Carolina at Chapel Hill, and he'll be talking to us about a study that he's conducted a few years ago now, the Certified Athletic Trainer's Knowledge and Perceptions of Post-Traumatic Osteoarthritis Following Knee Injury. The manuscript for this paper is currently available on the JAT website, and it will actually be one of the featured articles in a special issue of the Journal of Athletic Training on post-traumatic osteoarthritis that will go to press in May, just in time for Arthritis Month. So I'd like to welcome Brian.
Thanks, Abby. Thank you all for joining in today, and thank you to the ATOAC for hosting this webinar. First, let me see if I have. All right, first I'd like to just thank the co-authors on this paper. This was actually my first time venturing into doing a survey myself, so I appreciate all their help in getting this done. So what I'd like to talk about today is first just, give a brief introduction to knee injury and osteoarthritis, and maybe put this idea into a little bit of context of why we actually did this study. Then I kind of want to talk about what we learned about knowledge and perception of osteoarthritis and post-traumatic osteoarthritis in athletic trainers. And, really what I'm interested in is then, hopefully opening up a little bit of discussion about how these data, may impact specifically clinicians, educators, and researchers that are interested in improving, our knowledge base around post-traumatic OA and actually helping to treat patients a little bit better as we move forward. So first, I think it's always interesting and important to, introduce, this problem. One of the challenges I think we face in advocating for the importance of treating joint-related disease in our society is that the public doesn't necessarily see musculoskeletal disease as a cause of death, and I think therefore musculoskeletal disease is not often taken as seriously as many of these other disease states that we see on this figure here. But we do see on this figure that's produced by the Bone and Joint Initiative that musculoskeletal diseases cause more disability than any of these other diseases in the United States. So while musculoskeletal disease does not directly cause death, I think it does significantly affect our ability to move, which makes people who have musculoskeletal disease prone to developing a lot of these other physical activity related diseases like cardiovascular disease, diabetes, that will go on to directly cause death. So I often see our musculoskeletal disease not only as a major, a category that impacts disability, but also a gateway to many of these other diseases that could cause much serious issues with health. When we look at, what's really causing musculoskeletal disability, it really is joint-related pathology, all right? And we see that, the knee actually ranks up as one of the major joints that's causing disability in the United States. So when we look at what's, causing a lot of that knee-related pain, all right, it is knee osteoarthritis. And if we just think about the burden of knee osteoarthritis itself, it is the 11th leading cause of global disability. And in the U.S., with all people, it is about 5% of the U.S. population has knee arthritis. And if you look at people over 60, it jumps, a little bit higher up. It's a, prevalence of almost 16%. So the median age of diagnosis of knee arthritis in the United States is 55 years old. And I guess the older I get, the younger that number becomes. And, you think that at this age, there's still a lot of life that people are going to be living, with this debilitating disease. And if we put all of those years lived with disability, it is, mind-boggling how many, years lived with disability will actually accumulate over time. So we think about osteoarthritis risk and what actually makes someone susceptible to osteoarthritis. I think we could really think about it as we have individual susceptibility. So someone's age, sex, obesity, their heredity, their genetics, diet, race, bone metabolism can all make somebody, that individual, susceptible to developing osteoarthritis. And then we can think about that joint itself. All right, that joint can become susceptible to OA, and those together really make up someone's osteoarthritis susceptibility. One of the things that we see impacts this joint susceptibility is injury, and that's kind of what we're interested in talking about today. So we see that overall in all knee OA related cases that it's about 12% of these occur following an injury, and this is probably a low estimate at this point, but it's kind of the best estimate that we have of the general public. And because these knee injuries are more common in younger people, all right, people who actually develop knee osteoarthritis, but post-traumatic knee osteoarthritis may actually be younger than those who develop idiopathic OA. And because these younger people would desire more higher levels of activity, we often see that PTOA, or post-traumatic OA, actually causes more disability than idiopathic OA. There's also reports that outcomes are worse following joint replacement in people who have had post-traumatic OA, compared to those who have idiopathic OA. And some hypotheses around this is that one, that these people would want more activity and the prosthetics are not necessarily holding up as well, and that it's the potential for structural changes of the joint prior to actually putting on those prosthetics makes it less likely that they'll have as good of a fit. So we see that there are worse outcomes after joint replacement in people with post-traumatic OA. This is a study that we did a couple years ago where we looked at the prevalence of post-traumatic osteoarthritis after being ACL reconstructed versus just remaining deficient. And we looked at this a variety of different ways. I think the major points to this were that in the first decade, whether you were reconstructed or you remain deficient, the prevalence of radiographic osteoarthritis at that point was 36 and 34% respectively. So regardless of reconstruction status, after that first decade, we're seeing 1 in 3 ACL injured patients developing PTOA. And I think that number, along with how fast it happens, is quite staggering. When we looked at it about 2 decades out, we saw that in our ACL reconstructed group that it was almost 50%. So you can think of that young person who is developing or who has that injury at age 20, all right? By age 40, it's really a coin flip of whether they have, post-traumatic OA or not. So what really causes post-traumatic OA or osteoarthritis in general? I think our understanding of the pathophysiology is becoming a little bit more sophisticated. I think we used to think that knee OA was really a result of the degeneration of the cartilage at the knee. What we're understanding now is that there's really many different tissues that are involved in the development of osteoarthritis. I have them listed there on the side. So the new way to think about this is that we have many different phenotypes that actually are incorporated in this term or this condition, osteoarthritis. And realistically, our patients may have unique contributions from all of these different tissue types or tissue pathologies that might actually cause or culminate in knee OA. So this idea of osteoarthritis really may just be the end stage of many different pathological changes, in each one of our patients, which I think makes it very hard to treat with a one-size-fits-all treatment. The other issue with treating osteoarthritis is that we often don't know someone has it until they're in late stage OA, where we actually are seeing changes in the joint space, and we actually might see osteophytes forming. So the issue is that we're treating people when they've already had structural damage, and not treating them when they might be having the metabolic changes that will go on to have OA. And some of the analogies to this are giving somebody statins for high cholesterol while they're having a heart attack. All right, so we're actually potentially treating people way too late. There is evidence that after an ACL tear, that the composition of many of these tissues that we're worried about is changing much earlier, and this can be at within that first year. So some of the more recent MRI studies that are able to actually look at compositional changes within the cartilage have kind of identified this hypothesis. So if you look here to the right, this is called T1 row MRI, and basically it's used to actually look at proteoglycan density in the cartilage. And we know that decreased proteoglycan density is actually indicative of early osteoarthritic changes. So if you were to just look at the structure of the cartilage here, it looks actually pretty good. But when we're able to look at the composition, and this is kind of a heat map of the proteoglycan density, our normal people are kind of in this bluish area. All right, we're actually seeing deficits, changes, where that red is, in proteoglycans, and this is actually a picture of one of our patients 1 year post-ACL reconstruction. So again, these changes, if you were to just look at thickness, are not seen, all right, but the compositional differences are already starting 1 year out. So if we think about our disconnect, right, in our standard of care, we have our ACL injury, and then 10 years later, they have knee OA. And what are we doing in between, really to address this problem? I think, we have our reconstruction and our rehab that happen anywhere between day 2 and, in 9 months commonly now. But then people return to physical activity. And we really don't do much at this point, where osteoarthritis and these arthritic changes, to the joint tissues are really happening, under our nose. So I think some of the barriers, all right, and trying to set up new strategies to prevent PTOA are that, we really don't have a great ways to identify those who are going to develop OA. We don't necessarily have a clear management strategy yet for PTOA. But another major barrier, if we were to actually be able to start to address these first two that we kind of were thinking about 2 years ago now, was that we really don't know what the knowledge and perceptions surrounding PTOA are, and many of the clinicians that will go on to treat these people. All right, so our thought was that if we could identify some of those barriers early, we could start to address those while we're concurrently trying to improve our identification strategies and our management of this disease. So what we did, and Abby talked about the paper that is, I guess, online now, is that we developed a survey, really that, with 2 sections that included knowledge and perceptions of the risk of osteoarthritis, knee osteoarthritis, and management strategies of osteoarthritis. So we sent this out to certified athletic trainers to kind of gauge where we were at this point when looking at these 2 aspects of understanding risk and therapeutic management. So the knowledge and perceptions of knee osteoarthritis survey, which we're calling the COPOIS, I guess now, was adapted from a similar survey in patients with knee OA that we worked with Dr. Kim Bennell at Melbourne. And that study is actually published now, where we did something very similar in patients with ACL reconstruction to gain their to gain understanding of their knowledge of the disease. So we adapted the survey from it because there was no similar survey. We basically had 5 different content experts that reviewed for content validity, and we piloted our survey among 15 athletic trainers to get a better idea of face validity, readability before we sent it out. Our survey was comprised of Likert scales, visual analog scales, multiple choice yes and no type questions. So we administered this online to 2,000 athletic trainers on April 1st of 2014 using a Qualtrics platform. So we did this electronically, obviously. And we randomly sampled from all 10 NATA districts, and we opened up the survey for 14 days with reminders, day 3, 5, and 7. There were no incentives for completing it. We had 437 athletic trainers respond, so about 22% of the total sample. And about 60% of them indicated having a master's degree or higher. So you can see some of these initial demographics here to the right. One of the things that I think was interesting that we'll talk about a little later is we did ask if any of our participants actually had knee OA, and we'll see that almost a quarter of them did, and about 14% had a ACL injury in the past. You also see that the years of experience were somewhat evenly distributed, in these categories, with the largest being people that were had over 20 years of experience. So our largest, as far as age, our age was a little bit older than we were expecting, just looking at the NATA normative data, and our largest age range was between 22 and 37, so that was the largest group of people. And these are actually similar to other online surveys that were taken with completely different purposes, but in athletic trainers at the same time. So we think that we have a pretty good group of people that normally respond to surveys in this area. I think what's interesting is that almost half of the people that responded were actually in PT clinics. Another third almost worked in physician offices. So these people were probably around not only those at risk for knee OA, but they were probably around people that actually had, radiographic osteoarthritis at that point in time. We also saw that about 12% of our group also had a PT credential, and I think there were like 2 people that were, had an MD degree. So what I'd like to do, there was a lot in this survey. I'd like to report some of the key results at this point, and discuss each result briefly in the context of the current evidence. Here's the citation for the actual article if you're looking for more detail that I don't provide today. So one of our first questions that we asked was, can you identify the definition of osteoarthritis? And we had about 85% that can correctly identify osteoarthritis. And about 15% picked definitions. They were tripped up by definitions that were for osteoporosis or delayed onset muscle soreness or rheumatoid arthritis. 82% of the group said that they knew someone with osteoarthritis, which is, obviously very close to that group that could correctly identify, the definition of OA. If we look at the definition of OA, I think that 85% is good, but we probably need to improve that among our group. And I think it's important, not that I want you guys to sit here and read this definition, but there's 2 points that I want to make. So this is the definition right now of osteoarthritis from Orsi. One is this disease manifests first as a molecular derangement. So what I think is important to notice in this definition is that, much of the time where we're actually, seeing osteoarthritis develop, it may develop prior to us having, anatomical or physiological derangement. So this is the time where, athletic trainers may not be thinking that it's characterized as osteoarthritis, but these molecular changes, all right, that are going to end up leading to this joint breakdown that they may oftentimes characterize as osteoarthritis are still probably, osteoarthritis. The other part of this is that osteoarthritis is characterized by cartilage degradation, bone remodeling, osteophyte formation, joint inflammation, and loss of normal joint function, all right? And they all culminate in the illness of osteoarthritis. So just like we talked about before, right, this is not just cartilage breakdown. There's a lot of different tissue changes within this whole joint organ, right, that really could be classified as osteoarthritis. For example, a lot of people are talking about, fat pad dysfunction or synovitis being one of the early markers or, potential tissue changes that may lead to changes in the entire joint. The last question, and I'm jumping here, but the last question that we asked on the survey, and we did this not to bias them to the rest of the survey, was that we asked if they were aware of the condition term post-traumatic osteoarthritis. And we found that 60% were, but 40% of our cohort were not aware of the term post-traumatic osteoarthritis. So while athletic trainers understood, for the most part, 85% of them, what osteoarthritis is, they may not understand the specific phenotypes that are, comprised in post-traumatic OA. We asked other points, in understanding risk, and there was a bit of, most people agreed that these, full meniscectomy, being overweight, meniscal tears, altered biomechanics, ACL injury, partial meniscectomy, strength changes following injury would actually increase the risk of osteoarthritis. There was also a majority that thought smoking would increase the risk of osteoarthritis. So for the major things, we're actually seeing that most people overwhelmingly agreed that they would increase osteoarthritis. There is really, at this point, the effect of smoking on OA is controversial. I've cited a paper there that you can check out. The idea of sex on the risk of OA, we had about 40% of the group actually say that they were unsure of the role of sex on OA risk. And we see that for knee OA specifically, that females tend to be at a higher risk of developing OA. 40% of the cohort agreed that having a relative with OA increased the risk of knee OA. And again, this area is still understudied. I think specifically to post-traumatic OA, there's still a lot we don't know about the involvement of heredity in developing osteoarthritis following injury. when we looked at reducing risk and we asked them what different modifiable factors may help reduce risk, we only had about 51% agree that quadriceps strength would reduce the risk of knee osteoarthritis. And of 42% really there disagreed that quadriceps strength would reduce the risk of arthritis. And this was concerning in that this is probably one of the more modifiable risk factors that we're working with now to try to decrease OA. What we've seen is that, this is a relatively new meta-analysis that actually looked at prospectively looked at quadriceps strength and its association with developing osteoarthritis. So a relatively large cohort of patients that all came in without any baseline evidence of knee OA, and their follow-up testing was anywhere between 2 and 14 years after their initial radiographs. And we see that there's an overall odds are significantly greater, and that this actually may be greater in males for having a weak quadriceps associated with incidence knee OA. We've actually seen that quadriceps strength can predict people's function after having an ACL reconstruction. And we've actually looked at it multiple ways, and just to share this finding, we've looked at normalizing quadriceps strength after a unilateral ACL injury to the uninjured limb, and we tried to predict people who would be high functioners in IKDC score over 90, basically. And what we saw is that if we compared to the opposite limb, that people who actually were able to, who were above 96.5%, so that they were actually very, very symmetrical at that point, were 2.7 times higher odds of being a high functioner, so also demonstrating self-reported function over 90%. A better way that we think for determining who might be a high functioner, just looking at quadriceps strength, may actually be normalizing it to someone's body mass. So we found that this cutoff score of 3.1 Newton meters, and this was done isometrically at 90 degrees of knee flexion here, 3.1 Newton meters per kilogram of body mass actually made someone 8.15 times higher odds of actually having a high function. So what we're seeing is that quadriceps strength may actually affect incident OA, and having a higher strength actually makes you more likely to be a high functioner. We also found that athletic trainers may underestimate the risk of PTOA following an ACL tear. One of the questions we asked was if you had 100 patients who were 20 years old and ruptured their ACL, if they went on to go and get a ACL reconstruction versus remaining deficient, what would be the percentage that would develop knee osteoarthritis 1 decade, 2 decades, 3 and 4 decades out? And what we saw is that, going back to our previous, findings from our meta-analysis, was that in that first decade, athletic trainers significantly underestimated how much, the prevalence of osteoarthritis after an ACL injury, regardless of reconstruction or remaining deficient. Again, they significantly underestimated it, at 20 years out. I think one of the other interesting things is that they may overestimate how ACL reconstruction may decrease the risk of having osteoarthritis. So while they're underestimating the risk of osteoarthritis, they may be overestimating how beneficial ACL reconstruction is at decreasing that risk. So we were also interested in how people were, preventing PTOA. We saw that the majority of people that we surveyed treated patients with an ACL injury or treated people with a meniscal injury. But less than 75% felt that undertaking strategies to prevent knee osteoarthritis from developing after ACL injury or meniscal injury was important. And 37% felt that osteoarthritis, that their patient actually getting osteoarthritis, was not a major healthcare concern. And we know that this is a bit ridiculous, as OA in general is the 5th leading cause, or in the top 5 leading causes of disability. And knee osteoarthritis, that joint specifically, is the 11th leading cause of disability globally. I think this is an issue that there's that many people that don't think getting osteoarthritis is an issue, because at this point we have no disease-modifying interventions for osteoarthritis. Once you get it, there's really nothing that we can do to change the disease, the course of the disease. We can hopefully try to slow it down, but there's nothing to modify it at this point. So we see that our most effective intervention really is treating this end stage with knee replacement. And right now there is $42 billion really that are spent on an end stage knee OA. And I thought this was an interesting study, done in popular media here with NerdWallet. That they actually saw that 18, and this was in 2014, that 18 states joint replacement actually costs more than the annual household income at that point. So this is getting very expensive. So when we look at perception versus action, I thought this was quite interesting when we talk about how we can help athletic trainers actually treat people with, at risk of PTOA. So we asked our respondents, did you treat people with ACL injuries? And we saw that 93% of them did. 90% of them also believed that it increased the risk of actually getting osteoarthritis. 97% believed that it was appropriate for athletic trainers to actually explain that risk of osteoarthritis to their patients. But it severely dropped off when we asked, well, do you explain that risk to your patients? We saw that only 71% said they did. And again, that 71% also was the group that said that they actually did any strategies to decrease OA. So I think at this point we have to start to think, like, are there guidelines? What are our guidelines for managing OA, and how can we help implement these strategies? Because people aren't saying that they necessarily think it's inappropriate to explain the risk. They just may be having trouble doing it. There was a recent article that was written by Amanda Nelson, where she basically explained that that there weren't necessarily a lack of guidelines for managing OA. There's just a lack of ideas around implementing a lot of these guidelines. So that was kind of the conclusion from this study. And these were the guidelines, or the efforts that have been agreed upon by most of the guidelines out there. And I think for OA, for PTOA specifically, that we may need to tweak some of these guidelines, by adding some for PTOA versus just idiopathic OA. I think things like serial follow-ups and exams after return to play are going to be necessary. Obviously, education and self-management are things that we need to do in both PTOA and idiopathic OA. Exercise can be beneficial for both. I think we can add activity modifications for this group who may be returning back to activity after a major joint injury. And we may need to adjust weight loss as really weight management in this group. And many of these other concerns may not be as important for PTOA as they are for idiopathic OA. So when we actually look at how knowledge affects behavior from the study, those who were aware of PTOA, when we asked them, are you aware of post-traumatic osteoarthritis, were more likely to explain the risk of PTOA to their patients after an ACL injury. All right, so 69% of the group that said that they knew what PTOA was explained the risk, while only 31% explained the risk if they didn't know what PTOA is, but they knew what OA was. And then they provided prevention strategies after ACL injury at a higher percentage if they knew what PTOA was versus if they were not aware of that specific phenotypes of OA. And we saw similar findings to these percentages after meniscal injury. One of the things that I was interested in was, does a history of an ACL injury or a meniscal injury in our athletic trainers increase the odds that these athletic trainers would be aware of post-traumatic OA? And what we found was that it didn't. Which is interesting, because it may mean that this group who has an ACL injury was never actually told about their risk of post-traumatic OA. What we did find was that people who had arthritis already, were diagnosed with arthritis, were more aware of PTOA than the group that was had not been diagnosed with arthritis yet. So I think it's an interesting discussion to think about, but improving knowledge about a subject, I know, does not always significantly change someone's behavior. But we do know that in this group, those who are aware of post-traumatic OA were more likely to act in the clinic via either education of their patient or performing different strategies to help prevent OA. And those who have arthritis were actually more likely to be aware of specific phenotypes, within PTOA. So I also think that this was a finding that may impact, education later on. So one of the things that we found was that clinical experience impacted those who were more likely to be aware of post-traumatic OA, who were to explain the risk of OA to their patients and provide strategies to their patients. And what we saw was that the biggest disparity among the numbers were the group that was 1 to 5 years of experience, so right out of their entry-level education, versus the group that was 20+ years. So we saw that this group who was younger, all right, did not have as much awareness and did not perform strategies to kind of decrease this risk, which may mean that our education is not doing what it needs to do to improve the knowledge in this group of people. And I don't think that the risks of PTOA and PTOA prevention strategies are consistently taught in entry-level athletic training education. So, I also looked at just that group of people who identified as also having a PT degree, because I was wondering, is it just entry-level athletic training that has this issue, or is it allied health professions? And what we saw is that 90%, so a little bit higher than athletic trainers, PTs correctly identified the definition of OA. 46%, so very similar, felt that OA was not a major healthcare concern in their patients after ACL or meniscal injury. And still a quarter were not aware of post-traumatic OA. And we looked at that same breakdown here. We saw that while most of them treated and people with ACL or meniscus injuries and felt that it increased the risk of OA and felt that it was appropriate to explain. Similarly, they did not explain the risk or provide strategies to decrease that risk of OA. We had a smaller percentage of people that did it, who were trained also as physical therapists. All right, so basically to kind of end this, I just want to bring up a few discussion points. Maybe just identifying goals that we can maybe take away from this data for clinicians, educators, and researchers at this point. And I'd be really interested to hear what everyone thinks about this. So, clinical goals, I think what we can do better now is probably patient education. And this could, this means, providing education about the disease itself, about osteoarthritis to our patients, and what really to expect moving forward, with this disease. Promote regular contact with medical providers for, checkups, even after they return to participation. Giving people joint protection strategies and ways that they can self-care moving forward. And I think another important aspect here is awareness of future treatment. So we know that, in the next decade here, the, medicine and a lot of our advances, for treating PTOA hopefully are moving substantially from where they are today. So making our patients aware that these treatments are coming out will be helpful for them, even after they may leave our care. I think it's important to kind of hit home with these patients that they, after a joint injury, they're living at a much higher risk of having a chronic disease like osteoarthritis. And they are going to spend more, I know I'm preaching to the choir here, but they're going to spend more of their life as a non-athlete than as a competitive athlete, which I think is, difficult to explain sometimes. As far as education goals, I think, entry-level athletic training may need to improve some of the didactic knowledge of PTOA pathogenesis, as well as risk factors and prevention strategies with our students. Clinical education, even if our students know about the risk of PTOA, they seem to have trouble educating the patients about this. So developing skills for patient education in this area may be important. And I think continuing it, Ed, will be important to just continue to develop these evidence-based reviews of clinical methods for preventing PTOA for athletic trainers moving forward. Finally, I still think our two big research goals, and I think these have come out of some of the evidence-based forums that we've done at the past at NATA, are really that we really need to focus as researchers on developing clinical methods for detecting patients who are most at risk for PTOA. I think that is one of the major things that I hear from clinicians that they really need, as well as developing therapeutic interventions and ways to actually implement these interventions to decrease the risk of PTOA and knee injury moving forward. So that's all I have for today. Thanks for listening. I'm excited to hear what people think.
So thank you, Brian, for a wonderful presentation. At this point, if anyone has any questions, there's a chat feature. You're more than welcome to type in a question. I can present it to Brian. Or you can also, if you click on the icon next to your name, you can unmute yourself. And if anyone has any questions, we can field those that way. And while you guys are thinking if you have any questions, or if, I'll go ahead and throw one out to you, Brian. So, the ATOAC put together a response to the new CATIE proposed standards when we transition to the entry level that includes educating students about osteoarthritis, and in particular post-traumatic osteoarthritis. So could you talk about that a little bit more? What advice would you give faculty who are trying to educate students, or what advice would you give students who may be listening right now about talking with athletes about post-traumatic osteoarthritis?
Yeah, that's a good question, Abby. I think that it's really interesting when you talk about athletes and their willingness to really take on risk, regardless if it's concussion or if it's post-traumatic OA. It's very difficult because they'll take on a huge amount of risk to do that sport or whatever the activity that they want to do. I think one of the things that may not necessarily be available to everybody at this point, but something that we've actually found to be somewhat helpful is actually showing them some of these degenerative changes. So we could tell people about the risk of arthritis, and that risk still is I think abstract and hard to understand. But we've actually brought those MRIs that I showed earlier in the presentation, where people could actually see changes in their own cartilage, and being able to actually see that, and this is anecdotal, is they've made it's made a bigger impact, I feel, than just showing people numbers, because I think showing numbers, you always think that's not going to be me, but actually seeing changes in yourself, I think is helpful. So again, I think that the other thing is and we talked about at the end, being able to not just talk about that person, but maybe talk to that person about the risk, but also linking some of their dysfunction, or if you can even show changes in physiology to that risk may be helpful. Does that answer your question, Abby?
Yeah, no, I think that's great. I think at this point we don't have a lot of answers to give people, unfortunately, and we're all kind of working toward that. But the more conversations like this that we can have about it, the closer we'll get to that goal of being able to help our next generation of athletic trainers. So are there any questions from anyone who's kind of sitting in the audience right now that they would like to ask Brian?
Or open up to the rest of the audience. I mean, I don't know.
Brian, this is Hannah, Old Dominion.
Hi, Hannah.
Hi, how are you?
Good.
Good. Thank you for the presentation. My question is related. You kind of listed some of the characteristics such as physical activity, but also weight and nutrition. Can you kind of talk a little bit about the athletic trainer's role in helping their patients understand health and wellness from a holistic view in the sense of physical activity and nutrition and weight, and whether or not you feel that that's also an area of education that we can improve to really help our patients who sustain these injuries live the healthiest life that they are able?
Yeah, absolutely. I mean, I think, for all of us, it's, just like you were saying, it's obvious that, being able to have a good nutrition and manage your weight is going to help with wellness and a variety of, not just with the joint injury itself. I think, there's also data out there to show that after an ACL injury, or a knee injury specifically, that, there is a increased risk of weight gain. There does not seem, we actually have another paper that we're working on right now with a group of people, some of them on this webinar right now, where we actually looked at, simple measures of like BMI and its, potential for actually predicting outcomes after an ACL. And it doesn't seem to be the best predictor, just because we don't know if that weight is coming from, an increase in muscle mass, which actually could be helpful, or if that is, non-lean mass that's actually, may increase the amount of load at that joint. So, I think that you know, talking with your patients about what's good mass to actually be increasing, and you know, I think that's where, you know, just like you were saying, nutrition comes into play. But it may not necessarily mean that increasing mass overall after an injury is a bad thing, because, you know, if we can actually make that muscle mass and potentially lower extremity muscle mass, that may be helpful for this group of people for improving outcomes.
Thank you.
But I do think that there is, you know, we keep saying that, you know, BMI or, you know, increase in non-lean body mass is a predictor of idiopathic OA. I don't think there's still a ton of evidence showing, you know, what we need to target this group of people, you know, after an injury, as far as, you know, figuring out like a BMI cutoff. It doesn't seem to be that simple.
Are there any other questions for Brian at this point? So, Brian, I'll ask you another question. Sorry, Michelle McClellan, I'm going to steal your question that you sent me earlier. Could you talk a little bit about any immediate treatment strategies that your group has worked on or observed, or anything that you've read coming out of other groups that we can use to kind of help? Obviously, we can't prevent this at this point, but delay any of the symptoms that we're seeing of PTOA?
I mean, as far as immediate within that first year, or immediate, like, you know, right after injury?
I would say kind of within that first year after injury.
Well, you know, I think one of the things that we're starting to look at is, like, you know, what is the appropriate loading, you know, coming back from injury. And I think some of the first things that we've seen is that, you know, intuitively think people who are going to be higher loaders, you know, meaning that they're actually, you know, increasing ground reaction force when they're doing things like walking or increasing loading rate, are going to be the ones that are going to have changes in metabolism that are going to put them at higher risk for actually getting PTOA. And what we're seeing is that in our groups, you know, whether, you know, they're at 2 to 5 years post ACL injury, or within the first 6 months after ACL injury, that a lot of times it's the people who come in who are offloading that injured limb compared to their uninjured limb. People who have less vertical ground reaction force during gait, people who have lower loading rates during gait, maybe those that are at higher risk, you know, of developing the OA. So I think that the question is, you know, maybe we need to think about how we can better bring people back, as far as, you know, bringing them back to loading that joint correctly, you know, after a reconstruction, because it may not necessarily be what we intuitively thought of, you know, needing to offload them as much. You know, I think other things that we're looking at is that time between injury and surgery. We have some papers that we're going to be presenting, and some, you know, abstracts moving forward here in the next year, where we're seeing that people who are longer between injury and surgery are having some metabolic changes that might be consistent with OA, you know, early, the 6 months after the surgery. So I think those are just some newer things. I think that, you know, things that we've always talked about of improving strength, improving, you know, biomechanics are still important. But, you know, I think the idea of both symmetry and then the amount of load that people are putting on their knee are both important, and it's not one or the other. That answer your question, or was that just Brian rambling?
No, I think that was a good answer. All right, are there any other questions for Brian before we go ahead and wrap up here, since we're approaching our hour that we try to keep these to? All right, well, if there are no other questions, I'd like to thank everyone for joining us today. I'd like to thank Brian for a great talk and a good discussion. And we hope to have our next ATOAC webinar probably in January, so please stay tuned for announcements related to that. And then we will go ahead and post this on our YouTube page so that you can share this with colleagues who were not able to attend today. So Brian, thank you very much.
Thank you. Thank you, everyone.